Thank you. That was such a nice welcome into Grand Rounds. I feel like my quality of life has improved already. Um, okay, I'm going to spend a little bit more time giving Alaina's background because I feel like sometimes we're such a big group and sometimes we don't know our own very well. But I'm honored to be welcoming my colleague, mentor, and friend, Dr. Alaina Kipps. Dr. Kipps is a native Californian and a true coastal resident. She grew up in Santa Cruz. She graduated as the valedictorian of her class at USC. And a cool little fact there is that Rosa Parks was sitting on the stage with her when she gave her speech. She completed her MD at Harvard. She returned here for pediatrics residency at Stanford and then back to Boston Children's Hospital for her cardiology fellowship before taking a job at UCSF. So true coastal resident. I'm from the middle of the country where she probably doesn't even know where that is. After that, we were lucky enough at Stanford to recruit her back in 2012 to be director of our acute care cardiology unit, which she ran for many years until recently stepping down. Her academic focus has been centered around clinical effectiveness and QI. And within these realms, it's always been very clear that Dr. Kipps aims to improve how our patients, our staff, and families interact with the healthcare system. In 2014, she co-founded and continues to co-direct PAC3, which is the National Collaborative and Clinical Database for Acute Care Cardiology. Here, she led a national QI initiative that decreased how long our chest tubes stay in operatively by 20% and took an entire day off postoperative length of stay, which is a huge deal. Her work around schedule-based, family-centered rounds, her local work around the AAP roadmap project, and her guidance, along with that of our amazing psychologist Lauren Schneider, informing our Heart Center's mental health program, Thrive, which we'll get to hear about today as well, has really shaped how our Heart Center takes care of patients. So please join me in welcoming Dr. Kipps.
Good morning. Thank you so much, Magna, and Dr. Baker and the entire committee for Grand Rounds. It's been on my professional aspiration bucket list for some time, and so we're very happy to be here today to share a bit about this project when grasping for a good topic that could really relate and be instantly used by you all across many subspecialties in general pediatrics. I landed upon sharing my experience of the roadmap project, and then a bit at the end about the Thrive program. I don't have any conflicts of interest. I did want to acknowledge the ABP Foundation and David Margaret Clare Foundation for funding the roadmap project, and to Dr. Carol Lannon and her whole team for sharing many of the slides I'll share with you today. The learning objectives were sent out in the email and have been on the slide for a while, so I'll perhaps recoup some time and not enumerate these here, but just jump right into the first one. And I think we've all experienced this even from our early training days in pediatrics. And we know that patients and families, there's real emotional health challenges associated with living with a chronic pediatric condition. The patients themselves experience stress, altered coping, it impacts all aspects of their lives. And families, parents, siblings, extended family members are really impacted as well. And it was some years back that these kids who had kind of the perfect outcome after tetralogy of Fallot repair. They were thriving in school. They were third graders now. They're on even competitive level soccer teams. And I could clearly see in either parent's eyes when they would come back every 6 months, every 12 months, just to check in. It'd always been good news after a relatively uncomplicated stay. And they were still holding their breath until I could say echo still looked good and things are still on track. And so it was well outside of the sort of assumed area where I really practice in acute care cardiology, getting those kids out of the CVICU where they're like, you're in the headlights, oh my gosh, really, are we ready for the floor? And then, yes, you're really, really ready for discharge now. Like that's kind of an assumed, but it was the emotional toll really reverberates for many years afterwards. And so this has been studied in many, many different conditions across many of our subspecialties, but I thought I might share this meta-analysis of many different health conditions. This included cerebral palsy, sickle cell, diabetes, spina bifida, kind of you name it. 35% of parents of affected kids met cutoffs for clinical depression compared to the 19% of the controls. Some 57% had anxiety compared to 38% of controls. And then zooming into mothers of kids with congenital anomalies, they had a higher mortality risk, specifically from cardiovascular disease. It's been very well studied in pediatric cardiology. We know that kids with CHD have 3 to 4 times the psychological needs compared to kids with other forms of chronic illness, not just compared to their healthy peers. Youth with CHD, they often endure many admissions, surgeries, ongoing events of medical trauma. And even kids like 4 to 9 years old who are outpatient and doing fairly well, there's a 7 times rate of anxiety, depression, and ADHD. And those kids' parents struggle as well. There's a 30% rate of post-traumatic stress, 25 to 50% of anxiety and or depression at some point or enduring. And this paper came out and very much was an inspiration for forming our group for Thrive, to create the Thrive program in late 2022. And it really is a call to action, as highlighted in the quote in pink. Collectively, we all, our heart center, our hospital, our health system, are called on to engage in the implementation of strategies to both prevent and alleviate the significant distress, and to support the resilience and the mental health as a part of routine care. And that's really what the Roadmap Project is about, is to integrate this into every clinic visit. And it really does impact back onto the kid, right? We're pediatricians, this is our calling. If we can help parental mental health, we're also helping the child directly. So there's emerging and established evidence along these lines. And in congenital heart disease specifically, it's really emerging as like one of these modifiable risk factors to optimize, in particular, their neurodevelopmental outcome. From a mother whose son has had hypoplastic left heart syndrome and has been incredibly involved since the early days of Roadmap and other collaboratives. She lent us these quotes in one of the papers on Roadmap, and highlighting that the stress, anxiety, trauma, and grief are as much a part of the medical journey as the specialized care, all the surgeries and hospitalizations. And in her experience, the chronic grief and anxiety of her son's heart disease has been as difficult to deal with as each of those surgeries. Although he had great care, world's best pediatric cardiac care teams, his emotional and mental health needs, as well as theirs as parents, were often overlooked. And it's really not news. This is a paper from 1991, like when I was in 8th grade. Our residents were born yet for 5 to 10 years. So it's concluded that clinicians working with kids in chronic health problems should always assess the psychosocial well-being. And yet, some 65% of us don't feel comfortable, as surveyed back in about 2014, indicating that we just lack the training in recognizing and treating mental health problems. Much more recently, 3,800 graduating pediatric subspecialty fellows were surveyed. Lots of interest, high level of interest in emotional and mental health needs of the kids that they were treating. 63%, they said they should, in fact, be a part of the solution. They should be responsible and not just turfing it to the general pediatrician or someone else. But only 20% reported a high level of competence in doing so. So that opportunity gap of 80% is pretty profound and inspired the Roadmap. This is more of the specifics, interest, responsibility, and competence, as I just mentioned. And it at a fairly large range. Shout out to our adolescent medicine graduating fellows from a few years ago. 58% of them felt like they had a pretty high degree of competence, but the rest of us fell in this 13 to 25% range. And in particular, nephrology, cardiology, and critical care medicine down in the 13% zone. So now we are very fortunate to have Meg Didier join us from Annapolis, Maryland, via Zoom. Thank you for Zoom. She's been a key advocate of the Roadmap project since the very beginning design phase. She's a longtime and current cardiology patient right here at Stanford, a key member of several cardiology learning collaboratives, including the Fontan Outcomes Network, and has served as Director of Patient Engagement for Sisters by Heart since 2021, as well as leading the Advanced Advocacy Academy at the Global Liver Institute since 2023. Meg, thanks so much for sharing with us today. Should click over and I'll advance your slides.
Wonderful. Thank you so very much. First and foremost, I want to say that I am beyond honored to be here and so grateful for each and every one of you. Clearly, you are interested in trying to figure out how to help your patients if you are in this room or viewing virtually. And so I can't thank you enough for making the effort to really look at us as whole people rather than just our heart and our data. Next slide, please. My journey begins in 1991. Born in a rural town in upstate New York, I was discharged at birth as a healthy baby. At 7 days old, my mom noticed my breathing was off, and being a first-time mom, she didn't know if she was being overly cautious, and so she called my grandmother. She immediately told her, "No, you need to take her in." My mom was 7 days post C-section, postpartum, and is now having to rush me to the hospital, not knowing if her brand new baby was dying or would even survive. As I arrived, it was clear to everyone that something was wrong. They told my mom that they did not like the looks of me and whisked me away out of her arms. My dad shortly followed after leaving work after finding this out, and the entire family waited to hear the plan. There were not diagnostic tools at the county hospital I lived in to look into my heart the way it needed to be. I was rushed to another hospital, ultimately ending up at the center in upstate New York that would diagnose me with hypoplastic left heart syndrome. This center, just hours away from CHOP, told my parents that they didn't know anyone doing well with HLHS, and the surgeries itself would more than likely kill me, and truly it would be worse for me to go ahead with treatment. If it was their child, they would take them home and let them die. My parents always say that they felt like they were being barbaric in the way that even wanting to have treatment options, and that's the way that they were being made to feel, is that I was just a test baby to them, and that was all that mattered. And so hearing that clearly, I can't even imagine how traumatizing that is. And also picking yourself up and trying to say, okay, let's logically think, what can we do here? Like that's just not helpful. I hear that my aunt got the nickname Lizard Face during this time period of my life. My parents found CHOP. In a matter of hours, I was on a helicopter being transferred. My mom tells me that when she got there, she found hope, but she was also in serious shock and recovering from major surgery. The trauma I mentioned truly came on full force when the team came to ask my parents what route they wanted to take for treatment. My mom looked at the team and said, "Can I make this decision tomorrow?" To date, she says she's mortified that even was something that crossed her mind, and just says to me constantly, my brain just wasn't functioning at the time. The team told her, no, you really need to make this decision now. I mean, clearly they needed to make the decision, but this goes to show that the journey and the mental health that goes into this is far beyond the surface. Next slide, please. Actually, next slide, please. Apologies. Okay, perfect. So picture yourself in the situation. I'm sure you are on it on a daily basis. A family just got their life rocked, shattered actually. You're envisioning what an outcome looks like for individuals with single ventricle. So what defines a successful outcome to you? Truly think about it. When you're in the position of diagnosing, when you are in the position of working with a family, when you're envisioning trying to explain what a successful outcome is, or even trying to envision it, what do you envision? I grew up having a supportive and progressive team, especially my surgical team, who told my parents to let me set my own limits. They would always say that they were taking a good heart muscle and putting it to efficient use. I seriously took that to heart, no pun intended. I became a high-level gymnast and was selected to be part of the national team called the Talent Opportunity Program, focused on expedited training in gymnastics to become elite level by the time you're 13 or 14. Ironically, you have to be chosen, or you are chosen to be a part of the program, and the attributes they look for are strength and endurance. I can imagine my parents were just as shocked as anyone else that they received that call that I was selected. I was also chosen to be a part of a two-page spread in the New Yorker around 4 years after my Fontan titled Perfect Form and shot by the renowned Martin Scholler. I later found out that they went into the gym at the camp I was at and attending and scouted 7 of the strongest looking gymnasts to choose from to be a part of this shoot. I was chosen out of hundreds of gymnasts at the camp, and no one knew it was happening, and no one could see my scar at that time. So I always find it interesting, what if they did? Would that have changed their mind? I always thought how funny it was thinking, oh, I really do think it's interesting over the fact that the amount of times I have heard they individuals with HLHS or single ventricle, or many individuals with CHD, they will never become a high level or partake in the Olympics within sports. I always thought it was funny and thinking about the variety of Olympic sports and how many of them are very low endurance, assuming that that was the concern. And so just imagine being told that we don't know that for sure. That part's not said. What part is said is they'll never become an Olympic athlete. That's already set in stone for me before I've even walked. My outcomes, again, have been nothing short of stellar. I have the most amazing daughter, and truthfully, it's thanks to Stanford. I carried and delivered her at Stanford in 2022. I actually chose Stanford. I get emotional every time I talk to her because I can't even express to you how grateful I am for everyone at Stanford for this. I actually chose Stanford because of the progressive approach that you all take and out of the box thinking, and just looking at the patient and the experience. And my experience with this team, the teams at Stanford have been phenomenal. Going from being told my entire life that there would be nothing worse than becoming a parent, truthfully, I had been told that verbatim multiple times, or becoming not a parent pregnant. Coming here and having a team with a plan and a process of testing and evaluation and an OB that focused on maternal CHD, sign me up. I actually moved to California specifically for that and to be able to be a part of Stanford. My husband's actually a travel nurse, and so he was able to take contracts nearby, which had been our plan for over 5 years, and that was why he became a travel nurse, is so that way he could take a contract next to Stanford, and that way we could be able to go there and have our daughter there. I have a career focus on advocacy. I'm married. Like I said, I recently moved to Annapolis. I enjoy hiking, backpack, traveling, exploring. I focus on patient engagement within the liver and cardiac space and have grown up with few complications. So I have a question. Is this the ideal outcome? Is this what you think about when you say this is exactly what I'm envisioning? Next slide, please. But what about the emotional impact of living and navigating chronic illness? What about this part of my journey? What about the impact of our mental health? Is this part of the journey that's accounted for when looking at outcomes? What about the doctor's visits, the neurodevelopmental impact, the feelings of isolation, growing up not knowing anyone like me? This has been absolutely the hardest part of my entire journey. Take the surgeries, take the procedures, take the needing to go see the doctor or going to see the cardiologist, take all of that. Being in a room when my friends are talking about their future and the plans that they have, and me having no idea if I'm going to be a part of it, I can't even begin to tell you the impact that has. I used my involvement in sports to validate that I was doing well. Once I was too injured to continue, that was all gone and the wall of emotions came over me. This inspired me to get involved. Next slide, please. You don't have to be a mental health specialist to make a difference. I had never, not once, been asked about my mental health as a patient. Every time I went in, it was texting is good, everything looks good, your heart looks good. That must mean that you feel great. And so because of that, I just continued to live in feeling of isolation. And so with the roadmap project, we've created simple steps to be able to take. Again, you don't have to be a mental health specialist to make a difference. Ask early, ask often. You may not get the response initially when you say, "Hi, how are you doing?" Just that question, "How are you doing?" can really just set off an entirely new conversation that a lot of times can even lead to understanding why symptoms are happening or understanding kind of the reason, the patients might not be adhering to their care plan. What can we do as collaborative? And a lot of times it starts with that question. And you may not, again, get a response, but the more times you ask, I feel as though I've seen it, the more times you have more of a response. Again, validate the stress of living with chronic illness. Simplest thing that you can say is, I hear you. I understand. There are others that feel very similar to this. Just knowing that, just that simple thing alone would have made the largest difference in my life. And I mean, I guess truthfully, I wouldn't probably be in this position of fighting as hard as I am and being a part of all of these incredible initiatives if I had had that, and if this was just happening, we wouldn't be a part of this. We wouldn't be driving this. And then third, connect to resources. We as patients aren't necessarily expecting you at many times. Actually, I guess sometimes I feel as though mental health, we feel as though everyone should have all the answers for us. But having these resources available and understanding what resources you have, whether internally, externally, are incredibly important. I know that we're going to be going more into that. So next slide, please. When I look into the future and I look at the roadmap project being a part of it for many years, we look at our 10-year vision. Where do we want to be in 10 years? So we celebrated that every individual with a chronic condition and their family is asked about their emotional health, feels acknowledged about their stress, and is connected to needed supports. Every individual, every visit, every time. Next slide, please. And so to leave you with I just wanted to leave you with 3 takeaways from this presentation. Having a chronic or medical condition or caring for a child with a chronic medical condition is incredibly hard. Incredibly hard. The journey is not linear. Every single time I have a little bump, I feel like my whole coping mechanisms need to be adjusted. Many times I find out my quality of life is going to be potentially impacted, whether that be new medications. There is an incredible stress mentally with trying to navigate also a healthcare system that's not set up for the patient. Often our subspecialists providers are our primary care team. A lot of times I would go to my cardiologist and try to figure out, why am I not getting medications for my mental health prescribed? Why will cardiology not do this? And why do they keep pushing me off? I thought cardiology, everything I do, everything that touches a part of me just goes through cardiology. And that's just how it is. And so I looked at my cardiologist almost as a PCP, not understanding the subspecialty and PCP and how you need both. And so just that simple explanation would have saved me so much trouble and confusion. And every patient and family experience is different. Our comfort with ability to disclose our challenges is impacted by many factors, including race, and ethnicity. So please keep this in mind. And again, follow those 3 steps. We'll be continuing to go through more about these steps and resources. But I really want to say thank you for listening to me. And please just ask early, ask often, validate, and provide resources. Those are the 3 simplest steps that you can do as a medical professional. You do not have to be a medical or a mental health specialist to make a difference. So thank you very much for listening.
Thank you so much, Meg. Really appreciate it. See me, but thank you. Um, so let's delve right in. She's really covered a lot of it, so it's fantastic. The stated aim, similar to the 10-year, stretch vision, is that everyone gets this kind of proactive support, promote emotional health as a routine part of excellent and equitable care. But how are we going to do this? How did the American Board of Pediatrics think that they could shift the waves of competence and engagement? Clearly this notion has been around, since I was at least an 8th grader. So the old way, and this type of slide has been in several brand rounds recently, including last week. The old way is really kind of linear and inefficient, and there's no feedback loop, and the patient experience and patients themselves are really not a part of the equation, and it doesn't work well. Whereas this newer way is more circular and everything feeds back upon itself. And the vision of a learning healthcare system really entails the generation and using real-time knowledge to improve outcomes, engaging with patients like Meg, with families, with communities, and in order to achieve high-value care and shift the culture of care. So a number of strategies and resources have been developed over the last several years. This all started back in September 2016. The American Board of Pediatrics held a meeting focused on partnering with patients and families, and it was a real overview of their strategic planning committee's conclusion that the most important gap in pediatric training and practice was the emotional, behavioral, and mental health of kids and teens. That led to the ABP funding the roadmap initiative beginning in February of 2017, and having Dr. Carol Lannon at the helm, who's established and helped many different learning collaboratives mature and thrive. So as mentioned, it was a real co-design effort. Then it was tested amongst 11 teams at 9 children's hospitals in both inpatient and outpatient settings, as well as in 4 different pediatric training programs. It was further refined in a 6-month webinar series with 15 cardiology teams, but they really couldn't bridge the gap of getting any type of outcome data, really hampered by COVID. So that led to the convening of the 23-24 collaborative of 32 teams across 15 hospitals, 15 subspecialties. And that's when we participated for the first time, not only in cardiology, but in developmental peds and adolescent medicine. Here's the pictorial of all of the different peds hospitals, ours included. And then the product of all 3 of those initiatives and waves of engagement is this beautiful change package and a really engaging, easy to navigate website that you can find and explore later. Of course, rooted in quality improvement science, you're going to have a key driver diagram, and a lot of this work was centered at Cincinnati, and their Anderson Center is incredible at ushering this type of improvement forward. And so in bigger format, we've got the 4 pillars. Many of these Meg beautifully enumerated earlier. So really raising awareness amongst ourselves, our staff, our colleagues about the emotional impact, to speak amongst all those people, engage with our social workers and other experts on creating that resource list so it's easy to do the right thing and distribute, whether electronically or by paper, to our patients and parents. To develop our own skills, again, that 80% gap in feeling well-skilled to even ask these questions, can connect with resources. And then, any QI project really needs a way of measuring, are we doing the process? Are we getting the outcome? And so building a way that's not going to get in your way of getting through clinic, of building some sort of assessment and routine clinical processes. So this is the QR code to the website, if you want to fire it up on your phone, and a list of just a handful of the many resources on there. And then, so these 32 teams, so we zoomed in, we had like 2 or 3 4-hour learning session webinars, and then interspersed between between those would be like 1 hour monthly webinars where teams would share out, and we'd get into small Zoom groups and discuss what's working, what's not working. And on the whole, the percent of visits and assessments of a patient or the family having this come up and get documented went from about 40% to 75% on the whole collaborative. We also made headway in every part of sort of the readiness checklist. Are we ready to engage in this work? So that, again, includes, it's pretty small here, but staff awareness and knowing what the crisis plan is if should you discover that someone is in crisis, developing that resource list pertinent to your subspecialty, and just gaining confidence in this. So the training programs really helped accelerate this as well, finding that it's the framework is useful for trainees and well-established faculty, that these are practical, useful, easy to adapt to both the virtual environment, in-person environment, and really can be applied across many clinical settings. So the 4 training programs used it as an educational curriculum series at MedStar Georgetown, part of the inpatient complex care rotation out at Cincy, the rheumatology and primary care clinics at UNC, and then developmental peds rotation at Nationwide. So many different flavors, and they all took away something and improved. This is another snapshot of the resources available on the website or in the change package. There's like one-pagers, like easy to digest, each illustrating a conversation about emotional health. And then they have 4 brief videos, like 5 minutes or less, depicting pediatric subspecialists, at that first time visit after, say, a new diagnosis of diabetes, or a well-established patient who's, weathering something. So nice to see examples of it in action. These are those 4 training programs, and I think I'll recuperate some time by skipping that. But I did want to relay what we used in the cardiology clinic for roadmap quite a bit. Because even though I think I was okay at doing this, I certainly wasn't as deliberate as when I engaged with the roadmap project. So where to start? This we really borrow heavily in one of the webinars, included a live presentation by Dr. Erica Sood. She published this in 2023, and it's a nice, easy framework, because I'd like to give you a tool that you can use like later this morning. So we're really normalizing, asking, pausing, and connecting. You're trying to avoid that sort of, I'm fine, like as you're, walking out and trying to get through your clinic. So to normalize, one of the most powerful things that we really can do is just to communicate that the emotional difficulties are common and expected in this situation. A lot of people have no idea that the emotional toll, and they think they're, they're alone, and we want to alleviate that. So some examples of things what one might say, and Meg gave a number of examples. So I know from working with other kids, it's really common to feel down, depressed, anxious, what have you, whatever stressor involved. Or just normalizing the fact that you're going to be asking, like, this is a new practice of mine, or I'd like to be deliberate and like ask you about this. Because towards the end of a visit that might be wrapped, you're like, I want to fit it in. And so sometimes a little entry statement, like I ask about this because your emotional health is part of your overall well-being, as well as for the parents. And then you ask, right? Let's keep it simple. How are you doing? How has this illness impacted you? How have you been feeling, recently, et cetera? You don't overthink it. And then pause, which none of us are very good at, but like try to, count to 10, and really, make eye contact. Don't work on your note. Communicate that you want to hear their answers. This might be the first time they may feel a little bit caught off guard. By normalizing the fact that you're going to be asking at every subsequent visit, it plants a seed, and maybe next time they'll be able to share. And then make some connections, right? Restate that normalization. Thank you for sharing. It sounds like this has been a hard time. What are their current supports? What supports have they sought and felt barriers to getting? Who have they met with? Who could they meet with that day, or within a short period of time? This is Diane Pickles again, just relaying just how key it is to ask, early and often, as Meg said, opening the door for honest discussion and just how powerful it is just to normalize just how powerful the emotional impact is. But you might be thinking, sure, great, yeah. Here's 6 barriers that those many, many people and many teams and many hospitals came up with, and it was, recurring themes. I don't want to open Pandora's box. I don't have time to add emotional health assessment to the medical visit. Really, in my experience, over doing this for a year, it took me 2 minutes. That would be the average time. I think the max was 5. I never ran into someone that it was an absolute crisis, but I was prepared should that come up. And so Corey Stryver, a colleague of mine out at Nationwide, I've learned that it takes little time to validate the stress, and I have the confidence to do that now. She's participated for a number of years. I don't have to fit it all in one visit. All right, go forth. I don't have the skills. Hopefully this normalize, ask, pause, connect gives you a starting place. Really listening is the intervention needed. As Meg relayed, you don't need to be an expert. I don't know how to respond, just reflect and normalize. Ask about the available supports. If you really feel stuck, set up a meeting with someone who does this day in, day out as a true expert. It'll feel awkward. Yes, sometimes it did feel awkward. It was sort of felt like an added chunk to my visit, but I was like, darn it, I'm going to do this so we can hit 100% of our visits that given month for roadmap. Other things that came up amongst these teams, my team is already screening for depression and anxiety. So we are supporting mental health, and that is a huge and great component, and it's different. So we are focusing on that direct empathy, relation-based care, and having it come directly from you all. My time is not reimbursed, super valid. They came up with a whole billing strategy. And I think nowadays, this was before our time-based visits. So I think nowadays it's probably easy to accomplish. We don't have enough resources for patients with mental health diagnoses. Valid, super valid. One of the inspirations, since I didn't until Thrive have anyone really easily that I could connect my patients to should they need a true psychologist. So, but we can take steps, and there are things in the community, and we can get at them different ways, and we can advocate for more resources here at Packard. And then I have other people helping me with this, and it's just, again, please have it be directly from you also. Meg also addressed this, and this would easily fill another hour of grand rounds. The patient and parent partners have noted that comfort, ability to disclose challenges, willingness to be emotionally vulnerable are impacted by a multitude of things, including race and ethnicity. Pediatricians and specialists, we need to be deliberately to create normalcy in space. And the roadmap has an entire section dedicated to this key topic. I wanted to share a few slides on our own Stanford Cardiology roadmap journey and acknowledge my colleague, Dr. Megan Beatty, who was the site co-lead and did a ton of work. The two of us were the people, testing it in our own clinic spaces, and then we've since started the process of spreading throughout the cardiology division. We leaned heavily, as I mentioned, on normalize, ask, pause, connect. And then in order to make it easy to do the right thing, QI principles, we created this epic smart phrase for our notes, .cv roadmap. And then we had this nice drop-down menu. And just said, assess emotional health. And then usually, the vast majority, I would check family and patient demonstrated appropriately coping. And then I often would tell them about this wonderful resource we've had for a couple of years, Ollie's branch, which is a foundation that provides free or nearly free therapy should they want to engage with that. We also talked to our clinic social worker. We redeveloped that list of resources. We found out, I'd been here 12 years and I really didn't know what the crisis plan was should I encounter that. So I learned it. And then our documentation and engaging with this starting in the summer of 2023, our baseline about like 30%, grew quickly above the 80% goal and hit 100% a number of times. But that's just two of us. We got to spread this, right? And hopefully today's grand rounds will help this spread much more quickly. About a year ago, we socialized this, had a number of Zoom meetings with our the 10 key general outpatient cardiologists right on campus here. We also presented the roadmap to the full cardiology faculty meeting in June of 24. Felt very sponsored by Ann Dubin and our outpatient cardiology clinic. And in September 2024, I was asked at the wrap-up session, sort of the hooray, we're done with the roadmap collaborative, to present our story. And so I sent a quick survey out there. And, you know, there's still room to improve. This was like, I didn't ask them to like go back and do chart audits, right? But just their gestalt of like, have you been asking consistently for these kids who are coming back to your clinic about their emotional health? And about 6 of them were asking less than half the time. So room to improve, but perhaps more than they were before we engaged and gave them these resources. And they mentioned the same things: time constraints, fear of opening Pandora's box, and meant to but forgot. So in the last few minutes, I'd love to tell you a little bit about the Thrive program. This is a dedicated, and our vision is to offer holistic approach to the emotional health support of patients and families impacted by heart disease. And by supporting them across every stage of cardiac care journey, we want to nurture hope, resilience, and overall well-being, and give them access to all these wonderful people that are part of it. It was really inspired and accelerated and by engaging in a number of different centers that I'm lucky to get to know these people through PAC3 and other meetings. So out at Michigan, the MCOPE program by Melissa Cusano, the Thrive program, and they gave us the blessing to borrow and take their name, just not their logo. And out at Kansas City, the Cincinnati Children's Program is incredible. They call it their Heart and Mind Wellbeing Center. And then we have a patient and family action committee as part of PAC3, and they were saying this early and often, that emotional health is really what we should be focusing on. And Koala, we've engaged because all of this overlaps so much with our palliative care team and Koala colleagues, and learned a ton from them. Here, I won't read everybody's names since we're running short on time, but I'm co-directing it with Lauren Schneider, and we have onboarded and hired and are so elated to have Dr. Eliza Harley and Dr. Liz Loy, wave, as the 2 new psychologists for our program. All of these wonderful people, we've been Zooming together at least monthly for now just over 2 years. Many other Stanford advisors from the NICU with their successful program and longstanding, Dr. Sharon Williams, Director of Child Psychology, and Michelle Brown is our real clear link and consistent link to the Koala program. Briefly, Magda Patel, who introduced me earlier today, has spearheaded this project over the last year or so, and really boots on the ground, like right here at Packard, there is a huge need for this. So this really sort of inspires us to every day work towards our lofty vision. These were parents of kids who had at least 10 days in the CVICU, so which is not uncommon. And 50% had moderate anxiety, 20% moderate depression, and 12% PTSD. And you can see that was pretty consistent. So far, we have data analyzed for the 1 month and 3 month post-admission. And so it's clearly on campus. We have many kids and families to reach. The initial focus, so we've tripled in size in terms of our psychologists, but we have a lot of patients in the Heart Center, as many of you guys know. So our key focus is on the fetal to neonatal patient and parent, our general cardiology patients and parents, both inpatient and outpatient, as well as our hypertension clinic and inpatients. And then we seek to reach, but can't reach today, the expanded services listed there. And we've hit a number of milestones. I won't read all of these aloud, but we've reached some 20 inpatient families, rounded a lot with the team, gotten to know one another, have integrated with the cardiac neurodevelopmental rounds. Project Hope is set to launch very soon, spearheaded by Amelia, one of our former social workers. That'll be a patient peer mentoring program here. So former patients who are over 18 can mentor current patients with similar diagnoses, and hopefully we'll get to start that soon. And then within the month of January, we're set to start weekly inpatient parent support groups led by Dr. Eliza Harley, English and Spanish, which she's fluent in. So it's many things have happened since go live October 1st, and many more things to do in the near future. And I'll just take the last couple minutes to sort of briefly introduce two sort of, I call them extensions. This actually predates, and this video will play while I describe the journey. So we were fortunate, Terry Tacey, Shannon Feehan, and myself, to receive an auxiliaries grant in 2018, and then partnered with the design school here at Stanford for in-depth interviews of parents, providers. We did a thematic analysis and really gathered all the topics that we needed to go in depth with. And then many authors here, but across the country, came together to write each of these web pages. And then we needed to find someone to put it into a user-friendly format that works on, iPhone, iPad, computer. And so the result is this website that's, I think, fairly easy to navigate from any size screen. As soon as the English one was completely done, we got it into Spanish. And then more recently, in partnering with the Fetal Center at Montreal Children's Hospital, we have a global version that is in English and French. And so I just wanted to mention this here. This could be recreated in either this type of format or a simpler one. It really gathers logistic resources, mental health resources, and a lot of it, as I don't have the sound on, but we have these edited clips of multiple parents of kids with congenital heart disease talking about the emotional impact, the ups and downs in the ICU, the excitement, but also the terror of going home from the hospital. And most of the web pages have a little video component. Let's see if it wants. Another one bridging what we mentioned in the introduction, as well as the emotional care of our kids inpatient. As part of PAC3 a few years ago, we launched Talk, Read, Sing. Let's Talk About Hearts. This is really spearheaded by the parent lead of our Parent and Family Advocacy Committee for PAC3. And so these posters are up in all of our acute care cardiology rooms, and we distribute books, Hank the Heart, to anyone age 0 to 8. Really, I find it when I distribute books to give me joy as part of my service week. It's giving parents hope. It's always fun to give gifts, but I think it's giving them hope that the baby, like the one who spent the better part of his first year of life in Packard, that he'll grow up and be able to read and learn from that book and many others. It is really great for siblings. Their emotional health takes a toll as well, and being able to give them something to talk about it is great. So to wrap up, I hope that I've helped raise awareness on the importance about asking about emotional health as a routine entity, just like any part of your review systems. I hope that two, by sharing the CHD Care Compass or other much more simple lists of resources, that you feel empowered and that you can, making it easier to do the right thing. You could put together a list of resources. You probably already have one. The social workers here are incredible and have many of these. Three, I hope you feel empowered even as later this morning to use normalize, ask, pause, and connect strategy to start these 2-minute conversations in your clinics or in the inpatient realm. And then consider ways that you can sort of keep tabs on yourself. Are you engaging in this work? Are we accomplishing what Meg set for us, every patient, every individual, every time? Thank you.